Bienvenidos, everyone. Thank you for joining. I'm Dr. Daniel Turner Lloveras, the president of SaludConTech, founding member of the Latino Coalition Against COVID-19. Thank you for being here. This session, we have Carlos Rodarte. We want to make this as interactive as possible. He told me this ahead of time, that he doesn't like being on panels. He doesn't like one-way streets. He likes interactive, coming and going, hearing from the people. And so what we want to do is, please do not be shy in this session. This shyness is not allowed. We want to hear your thoughts. We want to hear what you're thinking. And please, right next to the chat button, there is a Q&A button. If you click on that, you can post your questions for Carlos. And what we'd like to do, if it's a good question and we have the time, we want to bring you on stage so that you can ask it yourself. So we can make this a little bit more interesting than your regular Zoom panel, okay? Carlos is a husband, a father, a founder. He's tinkering with business models to improve community health, co-founder of Veriteos, which I will let him get into with more details. Without further ado, please give it up for Carlos Rodarte.
Awesome. Great. Thank you, Daniel, and Maribel, and everyone for joining. I'm just, wow. I just want to thank everyone for being here, and I'm blown away, honestly, by the quality of the speakers and the passion from all of the policymakers and the entrepreneurs in the house. I see Eric in here. That morning panel was amazing. Abner and Mario and Christina. Ivelisse is just so powerful, and I feel like we've talked a lot about the need, but I just want to before I dive in, talk about how beautiful our community is, and honestly how resilient we're being. Some of the sessions are around misinformation and the jobs to be done, but I just want to take a moment and sit with the fact that we are resilient people, and we are very supportive of one another, and that good things can happen when we bond and build, starting with the community. So thanks again for joining. I will spend a little bit of time hitting on some very practical matters, namely how do you get paid as a digital health company, and how do you implement in the community setting in a way that drives social impact? So I'll go through various models that I've seen kind of work well and not so well in digital health. And then I'll spend a little bit of time talking about the approach that my new company is taking. But before I do that, I wanted to just share a little bit about my background and kind of the personal side to my story. I'm from the South Bay, born and raised in California. Not the fancy places, the beach cities, the multi-million-dollar RPV homes, but more Hawthorne, Lenox, and Inglewood. That's really shaped a lot about how I see the world. And I'll tell you, I don't remember ever using words like health equity. I don't remember ever using words, social determinants of health when I was growing up. I knew I was poor, and I grew up on government assistance, food stamps. I lived in converted garages, and I think only now am I realizing that there's a whole language by which to speak and make sense and contextualize our past. So I feel privileged to be able to play a role in bringing kind of my superpowers of communicating, bringing community together, and thinking creatively about business models to really drive towards impact. I've been in the digital health field for 10, 15 years now, in places like Patients Like Me, Health Catalyst. I advise a number of startups, deep tech to nutrition-oriented companies. I've run my own consulting company in the past, thinking about commercial models. And I think, there's a lot of work to be done. And I feel like the work that Daniel and Maribel and everyone is doing here can really showcase how when we work together as a community, we can have some tremendous impact. So I think, why have I focused personally in health and healthcare? It's deeply personal. I think many speakers today have already talked about their own personal stories. A lot of my childhood traumas, for example, are somehow rooted or have healthcare as a backdrop. And it hits close to home. I think there's a saying that my mom would always have, and so long in Spanish, so long as we have our health, we're okay. So no matter how bad things are or were, you always have to make sure to prioritize your health. So I think it's also a space that's filled with injustice. Sometimes it's explicit, other times it's more nuanced and it's harder to decipher. But when you really dig into the structural racism that's at play and how it impacts care access and care delivery, it's an area that can, if fixed, really empower people and create a more thriving society. And then lastly, it's a system based on incentives, and incentives can steer behavior. And there's a lot of alignment that we can do to make sure that those incentives are prioritizing the right kinds of people in the right kinds of settings. And all this to say that this is an area that there's a great amount of need, but I fundamentally think that it's fixable. Maybe not in the way that other people think it's fixable, but I think there are ways that we can certainly improve the system for the betterment of all. Switching gears a little bit into sort of digital health, and I won't spend a lot of time defining the space, but I will tell you, having been in the space for quite some time, it really feels like a boulevard of broken dreams and promises. I don't know how many of you like Green Day, probably, dating myself a little bit here. But, when I look at the amount of VC dollars, right, that are being invested in the category of digital health, and I look at some of the largest companies, most successful companies that have been around 5, 7, 8, 9 years, and I look at how many patients or individuals or people they've impacted with their technology, we're talking abysmally small numbers, 50,000, 70,000, 80,000 patients. And my question is, where is the money going? Who is actually benefiting from these solutions? And how is value even being determined in the space? So it's a very slippery slope to becoming jaded, and I don't think I am. I'm actually quite optimistic about the future. But I think that, based on what I've seen in terms of, leading companies, discussions with investors, and the need that I'm seeing at the community level, I just don't think that digital health has really reached its full potential by any stretch of the imagination. So which raises the question, right? Who is benefiting from digital health today? I certainly personally have used a lot of digital health apps. I know my mom has to some extent with some support. But I think to get to the answer, it's worth spending a couple of minutes looking at how these companies, digital health companies, go to market, how they generate revenue, and how they publish the evidence that they're generating and the outcomes that they're achieving. So, one of the things that, and this won't be new to a lot of people, I'll spend just a brief moment here, whether we're talking about a digital therapeutic that's pursuing a prescription route, an over-the-counter DTX that's more broadly accessible, and everything in between, all the way to basic apps. What I've seen, and I don't want to come across as these are all the wrong ways that, the industry has failed us. I'll take some level of ownership here. I've contributed to this, having built my own companies in the behavioral health space, been part of early stage ventures. You focus on big customers, on your core markets. You want to get that, deal with, the top 3 insurance company. You want to get those logos at, no matter the cost, to show your investors, to show your partners that you're credible. You're doing small pilots at a time. It feels like an uphill battle. The evidence is not representative oftentimes. What I mean by that is when you're trying to determine whether your product is working, you run a study, we look at the underlying demographics, and it's not representative of the communities at large, which I think invariably leads to a retrofitting of solutions to different populations in different settings that just don't quite match up. From the implementation side, there's custom one-off implementations that cost a lot of money. So companies are pursuing, self-insured employers, academic medical centers, large insurance companies, all having slightly different workflows, slightly different definitions of value. And lastly, there's really a limited set of outcomes being measured. There's almost a strict lens around, let's just show that we can improve, HbA1c or blood glucose levels, but not look at how it impacts, people's livability scores or their ability to return to work. So there's a lot of key outcomes that are not really incorporated into kind of the value assessment of a lot of these digital health tools. And, this is not true of all the companies, and I think this is starting to change, but these are some of the typical go-to-market considerations that I've seen and have contributed to. Now, I think all of this really is driven by a willingness to pay and not necessarily where the need is. And that's an unfortunate reality. This goes back to what I said at the beginning of this conversation. There really is a lot of people that are left behind. And personally, I have seen direct-to-consumer models that have been very problematic in terms of spend and reaching the right type of demographic or patient segment or individual. The B2B2C model has a host of challenges. I have battle wounds and scars, and it is, my time at Health Catalyst, just seeing how hard it is to go into health systems. It's very challenging. So I think a new model is needed, and I think it's one that's community-driven ultimately, that's bottom-up, that leverages a hyper-local sense of the community, the trusted networks, the people that can recognize faces and know names, that have lived experience, that can say, look, we have an ecosystem already in place, services being delivered, and we want to do more. We want to tech enable the way that we do things. And I was walking down this past December. I visited Nashville. It's the first trip that I had taken in over 2 years. It was a Rock Health event. I'm walking around in East Nashville and I see this mural, build up our community, and it completely resonated with me around the importance of basically thinking about leveraging these community organizations. So I think one misconception around going these non-traditional routes, going to the community wellness centers or the federally qualified health centers or your YMCAs or Planned Parenthoods or what have you, is that you won't make any money. And I think that what I'm seeing in this next generation of progressive companies, many of which have presented here earlier today, is that there doesn't really have to be a trade-off between making money, generating revenue, and doing good. Now, unfortunately, not everyone's definition of doing good will match what I think ours is. But I think that it is possible to think about this notion of what Michael Porter over at HBS calls creating shared value, if we want to get more academic about it. But on the same token, there also isn't a trade-off between making money and generating outcomes. I see this a lot in the behavioral health space. There are some companies that are retrofitting their solutions to meet the needs of the South, for example, unsuccessfully. However, there's also companies that are developing evidence in indigenous populations that are doing specific studies in Latinx, cities as well. So I think when I have conversations, when my team has conversations with community organizations, they're saying, hey, do the founders of these solutions get our problems, get our people? Do you think they're legitimate? I think that it's one of those things where I feel like the tide is turning. It's slow, but I feel like with all these conversations about health equity, having social impact, the quantification of social impact, as the lady from Vamos Ventures mentioned in the last talk, I think we'll be able to see doing good as a competitive differentiator that actually enables larger revenue to be had. So I think, so what do we do? I think we fundamentally start with the need. And Veriteos, my startup, is part of the Telehealth Equity Council. It's a relatively recent organization trying to improve telehealth access to as many people as possible in the US. There's 82 million people that have inadequate or no health insurance. These are a lot of people. When you compare that to the adoption of digital health today, there's a big gap. In the current model, it's clear to me that it's not working, and it's leading to more forms of incrementalism. So I think what we're doing is we're building a new promise, hopefully not a boulevard of broken dreams, but a channel that cares, a way to connect progressive health equity driven organizations to work together and focus on the underserved. Think about not just the clinical outcomes that matter to patients and clinicians and the traditional healthcare system, but all of these everyday outcomes, ADLs, the ability to work, not go under the poverty line, for example, all of the things that we're calling social determinants of health. And lastly, and I think this is a really important one, when we look at a lot of the distribution models or distribution channels that exist kind of in the consumer space, or even in kind of the pharmacy space, PBMs, the markups are quite substantial, and they act as a middleware that really doesn't provide a lot of value, but it adds a heck of a lot of cost to the overall system. So we think that there's a need to have payment models that are based on performance, and that there needs to be entities that take on risk. So what does that mean? Practically, what my company is doing is we're building what we're calling an outcomes network. Think of it as a matching system that connects. It's a membership organization, so we're able to screen and qualify organizations on both sides of this. But think digital health companies that have a health equity mindset, that are looking to have real meaningful impact on one side, and on the other side, a range of health promoting organizations. And here's where I think it gets really interesting. We're not just going after the traditional Fortune 100, companies or your top 20 health systems. We see this network as a way to bring together, establish some level of cohesion to a fragmented long tail ecosystem of potential customers for these digital health companies. That means working with unions. That means working with grocery, food store and respective chains that have substantial amounts of minimum wage workers. This means working with clinics. Certainly, we're in conversations with several groups that provide health services to migrant workers and farm workers. I can't think of a lot of digital health companies that are saying, "Hey, I wish I can go create reach a number of immigrants and migrant workers at scale." So we want to enable that type of channel thinking, and really be in a position where we not only play matchmaker, but we're also able to what we call front load the outcomes data that it's needed to prove out value. So bringing in the respective data, everyday outcomes from patients, from the digital health companies, from whatever setting they're implementing in, and really develop a model in which we're getting the sense of whether things are working in the community in real time, and then ultimately transact based on performance. And I think we've had a lot of conversations across multiple states Some great conversations in Nashville, I've mentioned, in Georgia, in Oklahoma, the Northeast, California, Texas. This model is really resonating. We're early stage, and we're honored to be able to share a little bit of our thinking. We'll be making some more announcements around how we're thinking about this. This is just a little bit more of a formal definition of the Outcomes Network, but we're really focused around enabling access to affordable and effective solutions to traditionally underserved patient communities. And I think throughout the day, there's been conversations around how do we capture more ethnicity data, or how do we measure the impact of digital health equity initiatives. And we think we can be one part of the solution, and one that provides more tooling and infrastructure to enable others to really benefit from this. So we want to be that supportive substrate in the community that augments workflows, not necessarily replaces them. So that's the main things that I wanted to share. I'll leave you. These are political times. I think I'm not one to get too much into politics, but I feel like these are hard times, and I feel like oftentimes we say words like, we have love and respect for each other, but I'm always reminded of James Baldwin's quote here. I won't read it fully, and I'll let you kind of digest it, but there's so much here that I think we can just see our own humanity and realize that, we're struggling and we're trying to do good. And we can certainly do more together than individually. So thank you for the time. I guess I ended up going through the time and not pausing for questions. So that's my bad, Daniel. But if you want to reach out and learn more about the Outcomes Network and some of what we're developing, my contact information is here. And again, thank you so much.
Yeah, and I'm back.
Nice.
Thank you. Thank you, Carlos, for what I found very eye-opening and sharing some thoughts that I think people are thinking, but not necessarily saying out loud. So I appreciate you, and I appreciate your honesty. We do have a question in the audience that I will see if they are able to come on stage. Mm-hmm. Here we go. So we actually...
Hello. Hi, Carlos.
Hola.
Hola. Sorry, let me get on camera.
Oh, hi. Nice. Thanks for joining. Are you on the East Coast too, or because it's?
I'm not. I'm in LA.
Okay.
Oh, I'm actually in South Bay, so we're.
Oh, nice. Where are you, in one of the nicer parts, or one of the parts where I grew up?
I'm in Harbor City. If you know that area, it's pretty.
Yeah, of course.
And Latino can't speak.
Nice medium.
If you don't mind sharing your name with everyone.
Yeah, of course. My name's Angelica Mondragon, and I'm a researcher, an evaluation researcher. I work at UCLA and also for the Latino Cancer Institute. Mm-hmm. So I had a question, Carlos, about safeguarding information. It's a really important topic that I think most of us miss in the digital realm. And it's also a real concern for our families, like what information is being gathered and where is it going? So I wanted to know if you have had any challenges, or like what your thoughts are about that.
Yeah, and I just, first and foremost, I want to thank you for that question. I'm such an advocate for digital rights, and I value privacy a lot. I've spoken on this in a number of occasions. I've been involved with several initiatives. Just by way of quick background on that, PCORnet out in California, at Health Catalyst, we manage the data for over 150 million patients in the US, over 300 data sources in total, where the EMR is just one. So data privacy, data safeguarding is a topic that's near and dear to me. My mental health startup captured, had passive sensing information, voice data, not just, not what you're saying, but how you're saying it, intonations, tonality, et cetera. And in every business that I've, been a part of, because I love sensors and wearables and all of these things, this question comes up. So I think, we initially, what I'll say is there is a conundrum that I have between how medical advancement happens and the sharing of information, and differentiating that from ownership and access. But what I will say is that the approach that we're taking at my latest company is to really be privacy oriented. Companies do not necessarily have to share their information. We can take a federated approach, and we can also apply different forms of analytics that look at just the metadata. So we don't often talk a lot about we'll be sharing more about our actual software stack, but this is something that we're deeply concerned about, broadly speaking, not just because it's lip service, but this has real world ramifications in terms of how people are treated in the real world and potential harm. So I'll be able to share a little bit more as we kind of build out more, but it's something that, on the pure safeguarding and storage and PHI, like there's some pretty basic credentialing, and but I think that people have to do more. And ultimately, we want to be in a position where through this outcomes network, we're actually enabling individuals, citizens, patients, people to be able to get that collective outcomes data set for themselves and be able to share it, draw, treat it as a utility. So I think in some ways, we're very people and patient-centered when it comes to that as well. Hopefully that gives you enough of a sense of our philosophy around it, even though I'm sure it lacks some of the super specifics that you're looking for.
Thank you. That's an excellent question. I'm glad she asked it. A follow-up to that is, I find that safeguarding privacy, HIPAA rules can sometimes get in the way of delivering care. And oftentimes the people who are afraid of the privacy, although HIPAA was created to protect patients, it's oftentimes used as a way of protecting hospitals or protecting healthcare systems from getting fines. And then at the end of the day, it then creates more barriers for patients in accessing care. Where do you draw the line in, we want to make sure that the information is safeguarded, particularly PHI. But when will we go to the patient and ask them, hey, so there's something called HIPAA. We'd like to do telehealth with you using WhatsApp, but we can't because we're afraid that we're going to get fined. But what's more important to you, your fear of your information getting hacked by hackers, or the benefit of being able to have a telehealth visit through WhatsApp, which is the only maybe modality that you feel comfortable with, and then being able to stay home and be with your family and save time and prevent exposure to COVID-19? Where do you draw that line?
It's a very good question, Daniel. And I think, there's a lot of conversations throughout the day focused around health literacy. And how do you think about kind of scientific knowledge? And I released this presentation. I think there's also knowledge around, data, healthcare data, and what it means and how it works. And these are meaty questions. But I think, to kind of answer it in a slightly different way, I think it comes down to the practical uses of why HIPAA matters. And I think, there's HIPAA right of access. And I think people are entitled to receive their medical information from their doctor. And, there's been analyses done around just how cumbersome some health systems make it to retrieve your data that could actually be life-saving for you. So I think that there's an empowerment angle here around helping people say, look, if you're in a situation where you're switching doctors or getting insurance, et cetera, it is your right to have access to your information. And at that point, let's talk about kind of risk reward, how you want to share it, dynamic consent models. The clinical trials world is, I think in some ways a little bit more advanced here, where they can do individual consents for how that data can be used for very specific research questions. But I think when you're talking about a public health emergency, we've seen kind of the HIPAA issues there, for better or worse. But I think it's a nuanced question. Our position is one around involving the patient around that conversation and providing the tooling for them to make the best possible decisions.
Well, thank you once again for joining us. I think everybody in the audience appreciated your wise words and sparked some new thoughts, new questions, ways of looking at the problem. Appreciate you coming and speaking to all of us. Until next time.
Thank you for having me. Take care.